So we've talked about the role of the advanced practice provider in that initial phase, making a diagnosis, setting expectations, but the APP role really is front and center as the treatment begins. So maybe you can talk about your role for patients as they start treatment with chemotherapy, immunotherapy, and targeted therapy, maybe specifically about toxicity management and setting expectations as they go through each of these modalities.
Okay, sure. I think at first you have to delineate it between which treatment, right? If it's chemotherapy versus target therapy versus immunotherapy, because they're going to be different. With chemotherapy, as we know, everyone knows, you come in a certain visits, you got your labs, you got to do all of that. But with target therapy, you know, it is not only, you know, once we get it ordered and they get the medication, is letting the patients know they need to come in 2 to 4 weeks, you know, for that initial, how are you tolerating the drug, you know.
Are you adherent to the drug? Are you taking
exactly,
are you taking
exactly,
the drug?
you know. And, you know, even before we get there, we need to also assess their level of comfortability with that, right? You know, their level of willingness to do that, you know, because you don't want to send them with oral. Everyone thinks oral is less, you know, problem because you don't have to come in the hospital, but it's more, you know, responsibility on the patient. So, you know, setting that when I go over with them, I go over, you know, you're coming back in 2 to 4 weeks after starting the medication. And then from there, we tend to see you on a monthly basis, warranting that there's no worsening symptoms and you don't need to come in earlier, but letting them know that if there are symptoms that arise outside of that time frame, that you are more than willing to give us a call and we'll get you in. And that's with target therapy. Now, immunotherapies, you know, that's a whole different thing too. You know, they come in anyway for an infusion and so forth. Every 3 to 4 or 2 or 3 weeks. Exactly. And I think even more so with immunotherapy is letting them know if you have diarrhea, still tell us. It doesn't mean that we're going to stop treatment. We just need to monitor that before it gets to a grade 4 or something like that. You know, I think reassuring patients that just because you have the symptoms, because again, this is advanced cancer, they're wanting this treatment as long as they can. Some patients feel nervous that, oh, if I tell, you know, the physician or the APP that I'm having these symptoms, then my treatment may be stopped. So
such a good point. I think you raise a lot of good points in that. And one is informing the patient to be proactive in letting us know. And also that them being proactive doesn't mean they're coming off of the drug. And I think you also do a nice job with the patient just in terms of setting the follow-up and also giving them a sense of what to call about. You know?
Because I have seen that if you do not set that, you know, standards of when you need to call, then sometimes you get some unnecessary phone calls or you get visits to the emergency room that may not need, but that may not warrant it, right? So I think that's why the importance of the chemo teach class, right? So we can go over things in a slower mechanism with caregivers there if possible, so that everyone is on the same page in terms of what the side effects are and when to call us.
And again, I can't stress how important that is, that we allow, you know, I tell patients, you know, generally, if they leave and they have any questions at all to call back, but I think it's nice to set some metrics to say, these are the things that you need to look out for, and you know, with perhaps targeted therapy, it's rash and diarrhea, maybe not so much now with Tagrisso being front line. There's not a lot of side effects with that drug. But just with immunotherapy, that the diarrhea is so important to assess, or acute shortness of breath. And of course, we've had a lot of this profound fatigue that ended up being fulminant hypothyroidism. Those are things I think that the APP is front and center. And it's not toxicity management only. I think as patients go through the treatment continuum, you're also oftentimes with me informing them how you think the drugs are working and what to expect if they're benefiting from the drug.
And I think also that follow-up or that carrying out treatment plan is also making sure that patients and their caregiver know the other resources in our facility, right? It's not just the physician and the APP or the pulmonologist or the pathologist. There is the social worker, there's the dietitian. You know, I think that's a great role of what the APP does well. We assess the needs that may not necessarily be clinical. It could be social.
I think having the right people at a center that can afford these services is great. You know, having the acupuncturist, the dietitian,
Right.
the social worker, those are also, communication is key,
Yes.
not only for the APP at the beginning of treatment, but really reaching out to other services, not just the pulmonologist and pathologist, but the dietitian, the social worker, the pain and palliative care specialist.
Exactly. Exactly.
You know, just briefly talk about how you interface with the pulmonologist or other disciplines as patients are going through,
Yeah.
because you do a lot of this. Patients come in, they have issues that arise as their cancer may grow or not grow or have toxicities. How important it is that the APP is still keeping in contact with the team?
Oh, it's very important. I know that at our institution, the communication or the relationship that we have already formed with Dr. Lerner is amazing, because at any time I could be seeing a patient and have concerns about, is there some pleural effusion there? Do we may need a tap and so forth, or is something seen on the scan? It's nothing but for me to give him a call, and he's so responsive. And I think that's very important, because once again, that improves patients' outcomes.
It does, and I think we have that data, that the more team approach you have, the better care is delivered to that patient. And you know, when we prescribe these targeted therapies, this is another issue with communication. Oftentimes we have to reach out to the pharmacists.
Absolutely.
And, you know,
and then not only reach out to the pharmacist, I'll touch on that, but also reassuring the patient that, you know, sometimes, yes, we put the prescription in, but it may take 5 or 7 business days, which I can imagine is frustrating for the patient. And then not only reaching out to the pharmacy, but the pharmacy also has to contact the insurance company. And if there is some delay, if it can't be dispensed from our institution, which is wonderful about doing it, then it has to be outside. And so that delays the time of treatment that can be nerve-wracking for a patient who's newly diagnosed.